starting the afternoon session. And this starts with Brunetti from the University of Montreal. I'm talking about mathematical models of premalignant disease phases.
Right. Can you hear me well? Yeah. Well, I first want to thank the organizer for inviting me to give this talk at the workshop. Like I said, today I'm going to talk about the mathematical modeling of premalignant and disease phases of acute myeloid to accelerate the preclinical development of new therapies. So as many of you know, acute myeloid leukemia is one of the most aggressive cancer leukemia subtype that exists. And it's characterized by this massive proliferation of myeloblasts in the bone marrow of patients that can no longer differentiate into fully mature blood cells. The standard of care for AML hasn't changed over 40 years, and it consists of this 7+3 regimen where we give for 7 days a continuous infusion of cytarabine in combination with an anthracycline for the first 3 days of the cycle intravenously. Now, when we look at the survival of patients over time, we have that younger patients have their 5-year survival significantly increased over the decade. However, this is mainly due to improvement in allogeneic stem cell transplantation strategies and supportive care. The issue is that this disease is prevalent in people that are 65 and older. And when we look at their survival, we see that it has not meaningfully improved over the years. So there's still a need to develop a novel therapeutic strategies for AML. But in order to do that, we need to understand how the disease developed. So on the slide here, I have a classical model of hematopoiesis on the left, where you have at the top of the hierarchy these hematopoietic stem cells that can self-renew and can differentiate into multipotent progenitors. Now, these multipotent progenitors can self-renew also to a certain extent, but most importantly, they are responsible for creating the 2 main lineages in the blood, either by their differentiation into multi-lymphoid progenitors and create the lymphoid cells, or the differentiate into the common myeloid progenitors and created the myeloid cell. Now, leukemia occurs when the cells at the top of the hierarchy acquire a primary mutation, which gives them a proliferation advantage. Now, these cells become pre-leukemic stem cells. These pre-LSCs now have a higher probability of acquiring secondary mutation. And if this mutation blocks their capacity to fully differentiate, they become LSCs. And then LSCs will produce the myeloblasts in a very similar fashion than HSC produce fully mature cells that are at the bottom of the hierarchy here. Now, the standard of care, what it does is that it kills the rapidly dividing myeloblasts, but it's not able to target LSCs, which then allows relapses of the disease. So our hypothesis is that if we're able to find a drug that can block LSC proliferation, either by their differentiation or their death, we could block altogether the progression of AML. But in order to develop a drug, especially in cancer, we face multiple challenges. So the drug development pipeline is a process that is extremely long and very expensive. So it consists of multiple steps with drug discovery, clinical testing, and approval for production. And we can utilize multiple ways in order to accelerate this process. The first one is through drug repurposing. Drug repurposing is basically using a already approved or previously approved drug for a new indication. And because we know already its toxicology and pharmacological properties, we can skip multiple steps in the pathway. Another very obvious strategy we can use is through the use of mathematical modeling. And that allows us really to decrease the cost and accelerate preclinical testing in particular. Now, with that in mind, our collaborator wanted to assess the anti-cancer property of a particular cardiac glycoside named proscalartin A. So cardiac glycosides are these sodium-potassium pump inhibitor that are currently approved for treatment of heart failure. And what they did is that they apply a 24-hour treatment of proscalartin A on different cancer cell lines. And then they assess the viability of each cell line by adding a different concentration of the drug. Now for all of the viability plot that I will show you, it's a measurement of how many cells survive the treatment over a control population. So what we can observe here is that the prostaglandin A is much more toxic, meaning that the concentration for half inhibition effect is much lower in these high MYC expressing leukemic cell lines than in the low MYC expressing cancer cell line here. Another interesting fact is that after a 48-hour treatment, the IC50 is lower for the leukemic cell lines than the maximum tolerated dose in human, which has clinical properties or applications, sorry. And what we can also see is that through their Western blotting, which measures the expression of a certain protein in relation to a control, such as actin, is that only the high expressing MYC leukemic cell line had a significant downregulation in the MYC protein after prostaglandin A treatment. I showed you all these results, but I never told you what is MYC. So MYC is a transcription factor that is a driver for many oncogenic programs. And high MYC expression usually leads to tumor initiation, progression, and maintenance. And it's associated with very aggressive cancer as well as poor prognosis. And what's interesting is that MYC not only shows genetic alteration in cancer, but also epigenetic changes. So as many of you know in this room, the post-translational modification on the histone tail domain alters gene expression by the change in chromatin structure. So what our collaborator did is that to assess whether prostaglandin A affected or give epigenetic changes to high MYC driven leukemia, they looked or they analyzed at how the drug affect the modification on the histone 3 tail domain. And what they saw is that there is a loss of H3 acetylation for multiple lysine residues, as well as a global loss of H3 acetylation after a small concentration of prostaglandin A treatment. And when they looked at gene expression for genes that had H3K27 acetylation in their promoter, they saw that the drug was able to downregulate MYC target genes, as well as multiple genes associated with metabolism and proliferation process. And those that were upregulated by the treatment were associated with apoptosis, negative regulation of proliferation, and cell differentiation. So one last thing that's interesting that they did is that they took primary human AML 8227 cells. They added a 6-day treatment of the drug prostaglandin A, and through flow cytometry, we're able to measure the viability of two populations of cell, CD34 negative non-leukemic stem cells and CD34 positive, CD38 negative enriched LSC populations. So here, through the gene set enrichment analysis, they saw that these non-LSCs, these CD34 negative, had a downregulation of MYC. And because of that, in our model later on, we will assume that hematopoietic stem cells behave similarly than these AML CD34 negative cells. So looking at the viability curves, they saw that prostaglandin A was much more toxic to those LSCs in blue than the non-LSC population here in red. So in parallel, our other collaborators performed an in silico identification of many anti-leukemic compounds that were able to target specific LSC signatures while not harming or enhancing HSC's specific gene programs. And then they performed an in vitro screening of these drugs with a favorable profile for different concentration on the same AML 8227 cells. And through flow cytometry, we were able to determine their viability for stem cell population, as well as mature myeloid cell populations. So with their screen, they identified 3 categories of drugs. The first one being the drugs that can target all leukemic populations. The second one were the drugs that could target LSC populations, but with a lower effectiveness against non-LSC populations. And the last one was drugs that had other targeting patterns. And we identified 2 excellent candidates of families of medication that had anti-LSC properties. The first one being the glucocorticoids, especially mometasone and budesonide. And the second one being as well some cardiac glycosides. And the reason why we identified these cells as well is that they retested those cells, but at the nanomolar range, which is their therapeutic window, and they reclassified the cardiac glycoside digoxin and ubiane into the second category. So just quickly here, looking at their cell viability curves, they tested for AML cells, and they found that the cardiac glycoside digoxin and ubiane were more toxic towards the leukemic stem cell population than the more differentiated leukemic cells. They also found that the sensitivity of the cells to the drug were dependent on the genetic or epigenetic differences between the AML. And finally, tested in comparison to healthy cord blood, they found that both drugs were more toxic towards the AML LSCs than normal HSCs. And for the glucocorticoids, what they saw is that they caused, at any concentration, a massive differentiation of LSCs into these CD15 positive, more mature cells, and that budesonide and mometasone, while they were toxic against LSCs, allowed this expansion of more mature leukemic cells. And same thing occurred when in comparison to normal cord blood, but those drugs were more, again, more toxic against the AML cell lines. So in a paper that we published earlier this year, our goal was to analyze the anti-LSC potential of all of these drugs that I presented in order to accelerate the introduction of a new drug that enable sustainable recovery in patients with AML. So to do so, we built a mechanistic model of the disease, and we combine in vitro cell viability models as well as the pharmacokinetics and pharmacodynamics models of all of these drugs to be able to kind of translate this in vitro data into humans. So we built a Moron process, and this Moron process follows in time a population of stem cell which has wild type HSC and leukemic stem cells with a proliferation driver. So at every time step, we choose randomly a cell for self-renewal. And at the same time, we choose a cell again randomly for death and symmetric differentiation. Now, this cell will leave the stem cell compartment. And at the next time step, the cell chosen for self-renewal will produce 2 identical daughter cells. What allows us to track the progression of AML is by following the fraction or the number of LSCs through time in the model. Now, the probability of either an HSC or an LSC to be chosen for either of these events depends on both their proliferation and differentiation advantages. And we know that AML mutations and anti-LSC drug concentration will modify the fitness landscape of those stem cells. So we came up with those three assumptions here. In absence of treatment, the oncogene carried by LSC convey 25% proliferation advantage over HSCs. The cardiac glycosides have anti-proliferative and apoptotic effect on leukemic cells, and the glucocorticoids block cell proliferation and cause cell death and differentiation in AML. So we constructed two terms. So the first one being a proliferation and a differentiation advantage that we apply to the transition probability of the Moran process through the use of weight factors that were concentration dependent. And these weight factors are SP and SD respectively. Yes.
One question, what is the differentiation
Ah,
advantage?
yes. In this case, it's the capacity at which a cell is picked for differentiation. And because, like I mentioned earlier, the drug, especially glucocorticoids, force those LSCs to differentiate with a higher efficacy than the hematopoietic stem cell, with this drug, LSCs become more fit to differentiate, if that makes sense.
Does differentiation come at the cost of proliferation? Is proliferation self-renewal?
In this case, yes. In this case,
aren't they two different sides of the same thing? So that there's more differentiation, there's less self-renewal. If that's symmetric and it's probabilistic.
Sorry, can you repeat the question?
So if a stem cell divides, your assumption is that it divides either into two stem cells or two differentiated cells?
It's always a symmetric division. So yeah, symmetric. So they're either chosen for producing two identical daughter cells, or it's chosen to be symmetrically differentiated or killed. So the Moran process skips all the division process that are asymmetric. So the rate at which it happens is not the true division rate.
Right. Normally, I think of differentiation as being a disadvantage to stem cells because the stem cells lose.
Yeah, I call it an advantage, but it is a disadvantage to their survival.
Okay.
Yeah. Okay. So here now are how we write the terms for the probability of selecting each of the cells for self-renewal and for differentiation or death. All right. If you proliferate, yeah, there's always a birth and a death process happening at the same time, at the same division event. Yeah.
So the population will only keep one.
Exactly, yes. Yeah. Yeah, exactly. Yeah. So for us to find the specific term for the different weight factors, what we did is that we use our cell viability curves that we have. So on the graph here, I have the cell viability for the HSCs in blue and the LSCs in red. And we fitted a Hill function to our data. And the shaded area is the 95% confidence interval made by bootstrapping. So now what this allows us to do. Yes?
Sorry, you most probably said that when do you measure the viability and how?
The viability was measured in vitro.
Yeah.
And what they did is that they apply a treatment on the Petri dish.
Yeah.
And they waited for 6 days.
Okay.
Yeah. After that, they looked at a control where they only put the MSO.
Yeah.
And they looked at how much cells survived in comparison to the control, and that's why it's over 100%. When there's no drug, it's 100%. Yeah.
And this means cells are exposed to the drug for basically 6 days.
6 days, yes. And then through flow cytometry, they derived the CD34 positive cells. And you may see here, I have on the top row the 3 cardiac glycoside, proscaline A, digoxin, and leuvain. I have the 2 glucocorticoids, budesonide and mometasone, but we also have the viability assays for cytarabine. And the reason why we were also interested in looking at cytarabine is that it's first part of the standard of care, but it's also currently used in high doses as consolidation therapy in patients. So we want to also examine the efficacy of those drugs in comparison to cytarabine. So now that we have the viability of each of the drug at any concentration, we can, yes.
On the drugs. So they're pretty comparable when there's no drug.
Yeah, they're all at 100%, meaning that.
But you assume that the LSC have a 25% advantage over the HSC.
These are, yeah.
Where does that?
They're normalized by a control. So here they're normalized by a population of the same population of leukemic cells, for example, applied a control to it. And then they compare leukemic cells with leukemic cells and hematopoietic cells with hematopoietic stem cells. Yeah, they measured it. It's an estimation that they did with an experiment in vitro early on. Yeah. So now with the viability for both HSCs and LLCs, we define the differentiation fitness and the proliferation fitness using these simple equations. So what you can see here is basically the leukemic stem cell will have a 25% proliferation advantage that will decrease as concentration is applied of the certain drug until it reaches 1. And then as you add more of the drug, there's they become even less fit to proliferate than HSCs. And for the differentiation fitness, this means at 0, it means that both HSCs and LCs differentiate at the same with the same probability. But as you increase more drug, as you add more drug, there is a higher chance of selecting an LSC for differentiation. There's a bit of weird stuff happening here just because of the fitting of the viability, which is hard to measure a neat ratio at the tail end of the Hill equations. So now we have the fitness at any concentration for any of the drugs. We could apply to our Morin process a fixed concentration of the drug, but these drugs were already pre-approved. So we have their pharmacokinetics. So what we can do with their pharmacokinetics, meaning we can simulate different treatment schedules. So here, to test our model, we used a daily intravenous administration for each of the drug, ranging from low to high doses. And these doses were used in the cell viability assays as well. And the reason why we use the intravenous administration, even though it's not very realistic to bring a patient every day in the clinic and give them an IV, is that if we don't see any advantage of the drug with an IV that gives 100% bioavailability, we won't see it as well when we test with oral administration. So now, with the plasma concentration of the drug in time and the value of the fitness, yes.
Curious. The 2 exponentials that you see so clearly in some of them, right? Is it because it's 2 compartments? I mean, where does that come from?
Yeah, some of them are 2 compartments. They come from data. Some of them are 2 compartments, some of them are 3 compartments.
Yeah, you can see.
yeah,
sort of,
you can see some of them.
It's very striking. It's
Mhm.
like I never see such clean.
They're zoomed in too. It's only like three days of
And
administration.
this is really based on experimental data.
Yeah. Yeah. This is a model that I produced the pharmacokinetics model based on the ODE system, and then I fitted it to data, and that's what I get.
see. But it's a new model that you get the parameters.
Exactly. Yeah.
But still.
Okay. Yeah, and so like I said, now we have the concentration of each of the drug at any time, and we also have the fitness for any concentration. So we can get the fitness at any time a cell divides in the Moran process. So we can simulate it. So here are the results for the cardiac glycosides. So the solid lines are the mean simulation for 100 iteration of the model. And the colored line corresponds to the different treatment schedule that we apply. The black line that's a bit hard to see on this graph is when we don't apply any treatment to the Moran process. So on the top, I have the number of leukemic stem cells with time, and we simulate it over a year. Now at the bottom, we have something that we call LSC viability. That is basically the number of leukemic stem cells under a certain treatment divided by the number of leukemic stem cells when no treatment is applied. So when LSCs remain at 100%, it means that the treatment has no effect on the LSC progression. And what we can see here is that high doses of cardiac glycosides can effectively decrease the expansion of LSC through time. However, we know that cardiac glycosides have an effective therapeutic window that's very close to their toxicity. So one way to measure their toxicity is by looking at their % inhibition of potassium uptake in red blood cells, so hyperkalemia. And again, through data, we can fit their toxicodynamics. And merging their toxicodynamics with the pharmacokinetics of the treatment schedule that we apply, we can get the pharmacokinetics, pharmacodynamics of each of the cardiac glycosides. And we can see that the high doses of proscaline A and digoxin that were effective are also highly toxic. So while there's while they're promising as anti-LSC drug, at these doses, it wouldn't be possible to give them to a patient.
Sorry, toxicity is measured how?
Yeah, they're measured, I think they measured through by looking at the concentration of potassium inside and outside the cell as you apply a certain doses of the cardiac glycoside. So the more potassium uptake it's blocking, the more toxic it becomes.
I mean, what I worry is that
Yep.
I don't understand about this, but you're interested in something that is happening. You're targeting the bone marrow,
Yeah.
right? But then you're affecting the heart, you're affecting everything,
Mm-hmm.
particularly the heart.
Mm-hmm.
So we should worry about toxicity in the heart, right?
Mm-hmm. Especially for these drugs, yeah.
Sorry?
Especially for these drugs, yeah.
Yeah, because you do it administered systemically, so.
Yep.
So that's not too dangerous.
Yes. Yeah, that would be
Even
super
if
dangerous.
The toxicity is really counted on the effects on things
Mhm.
like the heart.
Yeah, that's what I'm trying to prove here, that even though it would potentially be effective in reducing LSC burden, it would be super toxic to give these types of treatment to a patient.
In the different order.
Yeah. Okay, so we also simulated the model for the glucocorticoids and cytarabine. And and we can see as well that the medium doses of budesonide as well as low doses of mometasone is also able to deplete this overall expansion. But what's more interesting is that the high doses of mometasone are able to, over time, decrease the overall number of LSCs. So we then compared the efficacy of these two drugs to cytarabine. And here in the graph, what I show is the full change in HSC number and the full change of LSC number. And we looked at the value of either HSC or LSC at a certain time in the simulation. So 90 days because it's clinically relevant for measuring relapses in patients with AML. And what we did is that we normalized to the value here of the HSC that was remaining for a high dose of cytarabine. And what we can, and here, same as here, but for leukemic stem cells. And what we can see is that especially the low dose of metazone is better at preserving HSC numbers and decreasing LSC numbers. And we did a similar analysis, but with the normalizing by the lower dose of cytarabine. So in conclusion for this project, our results demonstrate that our mathematical framework can distinguish potential treatment regimens for candidate anti-LSC compounds. Our simulation predicts that this primary daily intravenous dose that we used of cardiac glycosides could lead to deadly side effects. So we would need to evaluate more in silico how different schedules and administration methods for those 3 cardiac glycosides can be changed to lower this toxicity associated risk. And finally, it highlights the potential of using budesonide and mometasone to possibly improve cytarabine consolidation therapy and induce complete remissions of patients. Yes.
Questions about the model structure. And what stage of the disease are you considering?
Yeah, good question. I forgot to tell you that. Here, what we consider would be a patient that went under standard of care, and that would be the pre-leukemic phase after full treatment.
The pre-leukemic phase?
Yeah, before relapse.
Oh, before. So it already got treated.
Yeah.
And that's why you're using a Moran process.
Mm-hmm.
Well, I'm not sure about the Moran process. Well, I guess the rationale would be that after treatment, it's more or less at some homeostatic level. But wouldn't you also have you also assume that the stem cells in principle have escaped homeostasis and they would just grow out and there is no Moran process, there is no constant population. Because if you have a constant population, you don't need to treat because you're limited by the constant population.
We could model it another way, of course. But the reason why we use the Moran process is that even though the leukemic stem cells could expand, they remain relatively rare in the body compared to those rapidly dividing myeloblasts that is really the characteristic of AML. So we just assume that the population remains relatively small to be considered as constant.
But then you should be treating the ones that are expanded, right? Because even if you get rid of the stem cells, they will still, the rapidly dividing cells are still the problem. And
well, that's why it's like after standard of care, it's like the myeloblasts are being removed. And then what happens to the pre-malignant phase of a relapsed leukemia?
Right, yeah. And yeah, I think what we have to be a little careful about is that there's intense competition going on that it can't expand and that can influence your genetics quite a bit.
Yeah, for sure. Yeah.
Okay, that's another question.
You can ask another question.
So still it's about the pharmacokinetic part. So the compartments that we're interested in for toxic effects are very different from the compartments we're interested in for the drug lab.
Yeah.
So how do you model the toxicity since we measure it just one? So I'm very curious as to why, because presumably the drug doesn't get to the part that gets
in pharmacokinetics, usually we assume that the effective compartment is in the blood.
I see. So in this case, it's the effective.
Yeah.
Okay. So it's the effective. Okay. Thank you.
You're welcome. All right. So now I want to change gear a bit, and I will show you some data that was not already published. So just I would like you to not record it. Yeah, thank you. So I want to talk to you about the disruption of epigenetic landscape in pre-leukemia. And like it was mentioned yesterday, pre-leukemia is this initial step that needs to occur before the development of AML, where hematopoietic stem cells acquire this mutation that gives them a proliferation, increase in proliferation rate. And I want to go back to this schematic here of the modification on the H3 tail domain. So there's a mutation that's called the H3K27M mutation that replaces the lysine with a methionine